department, but particularly I'd like to thank Dr. Martin Muir, who's one of the leaders in pediatric anesthesia in the world, and also to Benedicta, his wife, for being so hospitable to us here. We've enjoyed our trip so far. What I'd like to talk about is probably the paramount issue in pediatric anesthesia, not just in the U.S., but throughout the world, and that is anesthetic-induced developmental neurotoxicity. And the reason why this is really important is because this patient here, we take care of neonates like this almost every day. And many of us who have gray hairs will remember the time when we took care of these patients that they were very vulnerable to the depressant effects of anesthetic drugs. Many of us thought that halothane and isoflurane later on caused massive myocardial depression and respiratory depression, that we typically use this type of anesthetic. We would use air, nitrous oxide, some muscle relaxant, and hyperventilate the patient. And that was routine from 1980 and before that time. And certainly this was just basically chemical restraint. We were not anesthetizing these patients, and certainly there were some morbidity associated with not anesthetizing these patients for that matter. So it's not until the mid-80s where my colleagues at Boston, Sunny Anand and Paul Hickey, really looked at the biology, the neurobiology of the fetus and the newborn. And as you can see in this diagram from their publication from the New England Journal of Medicine, you see that even preterm, these neonates, these fetuses, have the circuitry to be able to sense and perceive pain. As you can see here, that myelination, cortical maturation, and even functional signs that they will sense pain in terms of EEG patterns. So it's studies like this and advances in monitoring, as well as the use of safe anesthetic drugs, that promoted the use of anesthetic drugs in these neonates, and that has become the fashion. But it's not until this paper that came out in 1999, in fact in January 1999, where perhaps some of the drugs that we use can be toxic to the neonatal brain. And just to show you, this is a study performed by Christy Okonomadu, Dr. Felipe's former colleague in Charity Hospital in Berlin, where she and her group from Dr. John Olney's lab at Washington University in St. Louis showed that the use of NMDA receptor blocker drugs, including ketamine, which is one of those anesthetic drugs that we typically use, leads to acceleration of neurodegeneration in the developing brain. And as you can see here, there's a panel of a neonatal mouse, a postnatal day 7 mouse rat that received just saline. When these rats receive ketamine or NMDA receptor blockers, you can see there's an increased darkening of some of the cells, indicating that neurodegeneration was occurring. And they went on so far as to say that these findings may have relevance to human neurodevelopmental outcomes involving prenatal and postnatal exposure to drugs. And it certainly bothered many of us in pediatric anesthesia that this may perhaps affect our practice of anesthetizing our patients. So many of us in the field thought that perhaps, since neuroapoptosis was occurring, that was just a natural acceleration of a process of neuronal pruning. That is, when we're all born, we have more neurons than we need. So it's this circuitry, the maturation, the central nervous system that allows pruning or neuroapoptosis to allow an intact circuit. So many of us thought that this had no functional problems. Furthermore, the doses that they used in that study was much higher than we typically use. In my own laboratory, my former fellow Hide Hayashi and I tried to duplicate how we use ketamine in our patients. And as you all know, we use ketamine as an induction drug. We'll give ketamine as an IM drug or as an IV drug to induce anesthesia, and that's it. And so what we did here was give a single dose of ketamine up to 25, 50, and 75 milligrams per kilogram, so almost 50 times more than we typically use in these rat pups, and found that there was no increases in neurodegeneration in all areas of the brain. So no effect of a single dose of ketamine. However, when you gave ketamine as a continuous dose, in a continuous dosing fashion, that is giving ketamine 7 times over the course of 9 hours, so having a plasma level of ketamine for a prolonged period of time, that's when we found that indeed there was increases in neuroapoptosis in many areas of the brain. So that shows you that indeed this whole issue of anesthetic-induced neurotoxicity involves using high doses of drugs for a prolonged period of time. Now, again, we thought perhaps this was just an acceleration of this normal process of neuronal apoptosis and had no physiological consequences, until this study by Vesna Jeretovic from the University of Virginia, a former fellow of John Onley from Washington University, where she showed that drugs that we typically use in the operating room, midazolam, isoflurane, and nitrous oxide, can produce neurodegeneration. And it is this combination of drugs, not singly. If you gave midazolam only, or isoflurane only, or nitrous oxide only, they did not increase neurodegeneration. It was the combination of all three for 6 hours that produced this effect. However, what was important is they allowed some of these rats to grow to adulthood and tested learning behaviors. And as you can show, as I can show you here in the right side panel, you can see that when they did the water maze as well as the radial arm maze, these are learning behavior type paradigms of seeing if these rats learn new behaviors with repeated exposures. They found that those rat pups who were exposed to this combination of drugs had decreased scores, then showing that there is functional consequence to the prolonged exposure to these anesthetic drugs. So now we have a problem, because indeed the anesthetic drugs that we use typically in the operating room can potentially do this to our patients, that is, produce long-term side effects. Furthermore, this issue is not only limited to the newborn rat. In this study by Laszlo Vuckich's group from University of Geneva here in Switzerland, they showed that when exposed older rats, postnatal day 16 rats, so the equivalent of teenage rats, to these anesthetic drugs, he found that they had increased density of their spines. Again, the spines are those connections between the cell bodies to allow intercellular communication and neuronal networks. And he found that this increase in synaptic density was actually dose dependent. So again, showing that this prolonged exposure with high doses of isoflurane produced these changes. Now the issue is whether or not this is significant. There are several investigators that say that this is the same histopathology and morphology that you see with autism spectrum disorders. But again, it's just speculative at this time, and it's really not proven to show any changes in behavior when exposed to older rats. Now, you have to compare some of those studies with some of the studies that came out negative. In this study by Andreas Lopke from the University of Cincinnati, he showed that when you expose neonatal mice to isoflurane for a prolonged period of time, he was able to find acute changes in neurodegeneration, finding that there was more neurons that have dropped out due to neuronal apoptosis. However, when he allowed these rat pups to grow to adulthood, and he actually started counting numbers of cells, there was no neuronal dropout. For some reason, from the time of their exposure to adulthood, neuronal plasticity allowed the formation of new neurons to fill in the dead neurons that occurred acutely. But more importantly, what he found was that when he allowed these rat pups to go to adulthood and then did some of these learning behavior measures, he found that the use of anesthetic drugs did not increase learning disabilities in these rat pups, showing again that perhaps there's no physiological consequence to this, because neuronal plasticity may be accommodating some of the neuronal loss that occurs acutely. And it's important to keep in mind that this study has been shown to be truth. A study that's being published, will probably be published in January, by Greg Stratman from the University of California, San Francisco, exposed rat pups to sevoflurane for a prolonged period of times. And then in one group, he allowed the rat pups to live in this very enriched environment with toys and allowed them to be stimulated during the time period. Allowed another sevoflurane group to have no stimulation, be isolated in the cage, and have a group where they had no sevoflurane at all. When he allowed these rat pups to grow to adulthood, he found that the rat pups who were exposed to sevoflurane and were raised in a very stimulating environment, enriched environment, he found that their behavior was the same as those rat pups who did not have any sevoflurane at all. Thus showing that perhaps the environment also has a large role to play, and also gives us credence that as parents, we can push our children hard so they'll learn how to new behaviors and accommodate their problems or deficiencies. Now, how about spinal anesthesia? Chuck Birdie and I in Boston looked at this issue, seeing if indeed spinal anesthesia causes neuroapoptosis. And what we did here was we had a control group with no stimulation, a group that received 3.75 milligrams per kilogram of bupivacaine spinally. And remember, these rat pups are about the size of my thumb. They're about 15 grams. So you can imagine trying to do a spinal anesthetic on this. But we were able to reliably produce spinal anesthetic with this compared to a short exposure to isoflurane and a long duration to isoflurane. As you can see here, the use of spinal anesthetics did not increase neuroapoptosis in the brain or the spinal cord, thus showing again that spinal anesthesia with bupivacaine is safe, but prolonged exposure to isoflurane is not and will cause apoptosis. So again, I want you to keep this study in mind because this is a preview of a clinical study that we're doing where we're comparing spinal versus general anesthesia in human patients. Now, how about many of you who take care of pregnant women and what's the effect? And certainly this is a large issue that's shown here in the Time magazine, where the first 9 months of development can affect the rest of the life of the fetus. And certainly many of your patients who are pregnant may ask, are the anesthetic drugs or the sedative drugs you're giving me, can that influence my fetus? This is a study by Wei Fang's group in University of Pennsylvania who exposed the mothers to isoflurane for 4 hours and showed that if you expose them to high concentrations of isoflurane, the fetuses had increased neuroapoptosis. So again, there's maternal fetal transfer of these drugs, and the fetus themselves are susceptible to this issue. Furthermore, in a study by Dr. Palmisani in the Brigham and Women's Hospital, Arvind showed that when you anesthetize pregnant rats at their last trimester with isoflurane for 4 hours of duration, when they tested the progeny of these pregnant rats, these showed that indeed you had decrements in learning behavior. So again, exposure to fetuses to isoflurane can lead to increased neuroapoptosis and also decreases in learning behavior and learning function as well. So again, this is an important issue that has to be made up. Now, how about a species closer to us? This study is from the FDA National Center for Toxicological Research, and Bill Slicker is the director of that group, and he reported that when they exposed rhesus monkeys as fetuses or as neonates and teenage monkeys to ketamine for 3 hours, a short duration, or 4 hours, a long duration, it's only the group that had the long duration that had neuroapoptosis, and those were exposed as fetuses and postnatal day 5. So again, there is a large dose of drugs used here. And when I asked them, you used such a large dose of drugs, why did you have to use the drugs? Because when we used this, we used only maybe 2 milligrams per kilo to induce these anesthesia. And Bill told me this is the dose that it took to keep the monkeys from biting his technicians. So it shows you again that there is perhaps a species-related difference between monkeys, rats, and humans. So it's something to keep in the back of your head. But again, it's this high dose that produced this. Now, what's more concerning is Bill Slicker's colleague, Merle Paul, allowed some of these monkeys to go to adulthood and did some cognitive testing. And in this operant battery test, what he did was he looked at behaviors that concern motivation. And what he found was that there was decrements in learning tasks, color position, and motivation in these monkeys who were exposed to ketamine for 48 hours and up to 3.5 years later. So again, showing that there is some functional consequence to prolonged exposure to anesthetic drugs in this group. And the same holds true for the use of volatile agents such as isoflurane, studied by Ansgar Brandbrink from Portland, Oregon, and John Olney's group in St. Louis, Missouri, looked at rhesus monkeys intubated and exposed to isoflurane. They found there was a 13-fold increase in neuroapoptosis in these monkeys compared to those who were not exposed. So you have to remember that many of these studies are done in the absence of painful stimulus. And you know, when we use these anesthetic drugs and sedatives, we use it in combination of a patient who may have may be undergoing a painful stimulus or surgery. And there's always absence of pain in this, so these patients are naive to pain. So what happens when you have concurrent pain in a situation which we use typically? So this is a study by Soriano, a former colleague of mine, where he tried to duplicate what we do in the neonatal intensive care unit, and that's basically taking heel sticks from these neonates to draw blood for hematocrit measurements. And he, instead of drawing blood out, he injected formalin in this group of rat pups and found that formalin increased neuronal activation and cell death in many areas of the brain. When he pre-medicated these rat pups with ketamine and a small dose of ketamine that does not produce neuroapoptosis, as you can see here, he found that it protected the neuronal excitation as well as prevented neuronal cell death. In the study that we're about to publish, this is some data that shows that even using high doses of ketamine, in this case we used 20 milligrams per kilogram of ketamine, and that resulted in high numbers of neuroapoptosis, you can see here, which corresponded to neurons. So you can see here the neurons. This is a panel that shows the cleaved caspase 3 activation, which is a sign of apoptosis, and here's the merged image. You can see that many of the neurons themselves became apoptotic. You can see that there's large increases in apoptosis in this group. However, when we gave ketamine, then painful stimulus with complete Freund's adjuvant, this is inflammatory stimulus, we found there's a decrease in apoptosis. So the concurrent pain should alleviate some of the neuroapoptosis that you get in this group of patients. Now, there have been many drugs that attenuate anesthetic-induced developmental neurotoxicity. Estradiol, erythropoietin, melatonin, bumetanide, a fluoride channel blocker, lithium, xenon, and dexmedetomidine have all been shown to prevent this process. And you can see that there are very few drugs that we use clinically, and certainly bumetanide is some drug that we could potentially use because it's basically a diuretic, and dexmedetomidine is something that we use clinically. However, the use of xenon, lithium, or melatonin may not be useful. So indeed, these drugs can prevent this. And when we've looked at it, it's basically changes in the cell surviving proteins that affect it, not alleviating the neurotoxic effect of the drug itself. So what are some of the mechanisms behind this? In this, you have to keep in mind that the immature neuron behaves differently to GABA stimulation compared to the mature neuron. When you excite the GABA receptor in an immature neuron, you actually have excitatory process. And that's because you have high concentrations of chloride inside. Stimulation of the GABA receptor will actually have a release of chloride, leading to depolarization. Blocking the sodium potassium chloride channel with bumetanide will stop that and indeed prevents some of the neuroapoptosis that may occur. When the neurons mature, GABA stimulation actually becomes inhibitory because there's a shift of these transporters that allow lower concentrations of chloride to exist intercellularly. So this is one of the mechanisms that occur. Another mechanism that has been espoused by Vesna Storovich is that prolonged exposure to isoflurane changes the mitochondrial morphology. You actually get denser, increased size of the mitochondria with less density. So you have mitochondrial dropout, which is a sign of toxicity in this case. Bill Slicker's group from the FDA says that prolonged exposure to ketamine leads to upregulation of NMDA receptor, and when you withdraw the ketamine, you have more NMDA receptors, therefore more channels for calcium to enter, leading to excitatory cell death, and also mitochondrial dysfunction. Again, these are all the pathways that lead to both necrosis and apoptosis. My group has been looking at some molecular biological pathways to this, and what we explored was the cell cycle. And as many of you know from your biology course, the cell cycle is the process where cells divide and mitose. So this is very common in development. However, pathological entry into the cell cycle leads to tumors and tumorigenesis and cancer. Neurons are different because neurons are postmitotic. Once they become differentiated, they cannot divide further. So many of these neurons, when they have expression of some of these cell cycle proteins, will die and using by a neurodegenerative process. And this has been shown to occur in Alzheimer's, traumatic brain injury, and stroke. So what we did was we looked at some of the proteins that are involved in the cell cycle pathway and found that they were all increased in a dose-dependent fashion by ketamine. You can cyclin D, CDK4, E2, F2, and BIM are all increased, and these are all members of the cell cycle pathway. And when we use small interfering RNA to block cyclin D translation, we found that this preserved the cell survival and actually was neuroprotective. So this is this cell cycling is one of the pathways to cell death in this process. So the important issue is what we find in rats applicable to humans, because certainly it's difficult to extrapolate these rodent experimental data because it's different. We have rat pups in a cage that with the mother, sometimes without the mother, and no physiological monitoring at all. Whereas when we're taking care of babies in the operating room, we're measuring the blood pressure, measuring end-dial CO2, temperature, as well as changing the concentration of drugs that we use. Here we give a set dose of anesthetics. However, when we anesthetize a patient, we only give them what they need. We'll probably give a large induction dose to allow endotracheal intubation. We'll let the anesthetic levels drop. We'll probably increase the anesthetic levels when they do the incision, then let it drop again as their blood pressure will allow. So indeed, we don't give the amount of drugs that we typically use in the experimental model to what we do in the operating room. But more importantly, the issue of whether or not anesthetic-induced neurotoxicity, if that exists, is really a huge question, because we certainly know that there are drugs that cause neurotoxicity. Alcohol leads to fetal alcohol syndrome. Anti-epileptic drugs lead to fetal malformation, developmental delay, and microcephaly. But many of us have used these drugs such as ketamine, isoflurane, and propofol. We still do not have a phenotype that shows that this causes any problems. Furthermore, there are other issues that are involved. When we take care of sick patients in the operating room, they also may have some genetic susceptibility to neurodegeneration. Many of you who take care of neonates in the neonatal intensive care unit will know that many of them are not well, and they perhaps may have some confounding variables that may decrease neurocognitive issues. So indeed, we have to keep that in mind when we look at these studies. And most importantly, we do not include patients in the ICU. Many of these neonates that are in the ICU are at a very vulnerable age. They get large doses of drugs because, as you know, they become tolerant to many of the anesthetic and sedative drugs that we use, and for long duration. Many of these neonates are ventilated for weeks to months at a time. So it's a group that is poorly studied, and again, it'd be difficult because, again, they maybe have other issues involved. Now, what are some of the clinical studies that have showed that there is a problem? This is a study by Koch, who is at Utrecht in Holland. And what he did was he looked at all of his friends' patients. He has a friend who's a pediatric urologist, and sent parental questionnaires for behavior to these parents, and found that indeed those who are less than 2 months of age at first surgery had an increased risk for behavioral problems as assessed by the parents, and was greater the younger they are. And another study by Lenasun's group in Columbia University in New York, what they did was they looked at the Medicare records, that's the records of all the patients that are seen in New York State, and found that those patients who had surgery at an early age had increased incidence of developmental and behavioral problems. They further looked at a subgroup of these patients comparing siblings, one sibling who did not have surgery compared to a sibling that did, and found that indeed the one that had surgery had increased behavioral problems. Now, in these very elegant studies from the Mayo Clinic group in Rochester, Minnesota, one of my former colleagues, Bob Wilder, reported this in Anesthesiology in 1999. And basically what they did was they looked at all their patients that they took care of from 1970 to 1982, and looked at the incidence of learning disabilities in patients who received no anesthesia, those who had one anesthetic exposure, and those who had multiple exposure. And what they found was, indeed, if you had multiple exposure to anesthetic drugs, that they had an increased risk of learning behaviors up to the age of 19. So this is a very interesting study. They further refined the study looking at exposure less than 4 years of age, and this is impressed in pediatrics, and found indeed that they had the same pattern where repeated exposure to anesthetic drugs had increased risk, incidence of learning disability. And they also had an increased risk for individualized educational plans, so special education for speech and language. But you have to keep in mind that these patients came from a cohort that were exposed to anesthetic drugs in 1970 to 1982. And many of these patients did not have pulse oximetry or capnography, and the drugs that they used were mostly halothane and nitrous oxide. So the modern anesthetic drugs were not available at that time. So that's something to keep in mind when you look at these studies. Now you have to compare those positive studies with some of the negative studies. And this is a study by Melkie Bartels from Holland, looking at twin-twin registries. And what they did, what her group did, was they looked at monozygotic twins and looked for anesthetic exposure in these patients, and found that those who were exposed to anesthetic drugs less than 3 years of age had lower educational achievement scores and more cognitive problems. Okay, that's something that you know. But what's interesting is she compared one twin who had surgery versus another twin who did not have surgery, and looked and see what their scores were, and they were all the same. So showing that, this shows that perhaps it may be the predisposition for surgery or having a surgical lesion that probably led to these developmental disorders rather than the exposure to anesthetic drugs itself. Now, and this is a more recent study by Tom Hansen's group in Denmark, and what he did was he found 2,500 patients undergoing hernia repair and looked at their academic scores at grade 9. And what he reported is something that we all knew. He reported that the girls were a lot smarter than the boys in this group. So that's something in yourself, so what? But what's more important is that he found there was no difference of those patients who had hernia surgery versus those who did not. So again, no effect of surgery itself. But you have to keep in mind that these patients had hernia surgeries, and typically hernia surgeries are less than an hour long, so very short exposure drugs with minimal doses of drugs at all. So it does not fulfill the criteria that we see in the laboratory. So how do we study the effect of anesthesia drugs on outcome? Because certainly the pathology of the surgical lesion itself may have some confounding variables, as well as the surgical manipulation, surgical stress can be problematic. Well, there are two prospective studies that are being done in the US. And one is the PANDA study, which is a multi-center collaborative group that's led by Lena Sun in New York, and is including 8 academic pediatric hospitals, including our own in Boston. And basically what it is an ambidextrous cohort study. That is, she's taking patients who had hernia surgery in the past and recruiting them with their siblings and doing prospective neurodevelopmental assessments at age 8 and 15. So perhaps they'll maybe be able to show something because they have the patients already, and this follow-up will probably show us whether or not there's differences in their neurodevelopmental scores. The study is underway. And another study that's underway is this GAS study, which is a multinational, multi-center collaborative group that's led by Andrew Davison from Australia, Mary Ellen McCann from my group in Boston, and Neil Morton in Glasgow. And they all have their corners of the world involved. And we're recruiting about 700 patients. And basically, it's a randomized controlled equivalence trial that shows, and our hypothesis is there should be no difference. And again, we can say this because we did the animal study comparing spinal versus a short duration anesthetic with isoflurane and found no difference at all. So we're comparing a bupivacaine spinal versus a sevoflurane and a general anesthetic. We're currently doing our 2-year follow-ups on Bayley scales of development, as well as a 5-year follow-up with a general pediatric assessment. So what do we tell parents? Certainly, many people are involved, and one is the Smart Touch collaboration between the FDA and International Anesthesia Research Society. And this is a sample of their recent newsletter showing that indeed they're trying to promulgate some of the studies so people know what's hot in the field. And they're also providing funding for small startups to look at this issue. The FDA has been involved from the start, and Bob Rappaport wrote this perspective in New England Journal of Medicine, showing that perhaps these findings should be of concern to the scientific and medical community, just calling to us to say that we should be aware of these issues in case our parents ask questions about it. But what did we decide on? And I'm involved with the FDA group, and I was at these two meetings, both in 1970 and 2007 and 2010. And what we finally decided after reviewing all the animal data and some of the retrospective studies, we found there was not adequate data to extrapolate these findings into our patients. Furthermore, there are more risks involved with anesthesia that should be kept in mind. And as we all know, apnea and hypertension is bad. So respiratory and hemodynamic morbidity is key. And we also should balance the risk of delaying surgery, because certainly delaying surgery can be problematic as well. And certainly when you look at these people I've listed here, and should be familiar to you, because these are the primary investigators of all those studies that I pointed out in animal studies. And in this next slide, the ones in blue are pediatric anesthesiologists, and Arvin is a OB anesthesiologist. We're still all anesthetizing our patients. We have not changed our practice. But that shows you that despite the fact that in our laboratories we can show there's a problem, we still feel confident that we're not harming our patients with our anesthetic drugs. So certainly what we should keep in mind is that we should know that this issue exists in the laboratory, and certainly scientists are really honing in on this. And you should reassure your parents that you're aware of this, that there are issues in the laboratory that are not relevant in the operating room. And certainly we should continue to anesthetize our babies and not throw the baby out with the bathwater. Thank you.